Hello, good morning, my dear friends. I hope you are all ready. Now, after about 2 minutes time, these MCQs will start, and each MCQ slide will be there for about 40 seconds. And after that, automatically, the slide will go to the next. So every time you get a question followed by 4 answers. So immediately you can note down on a piece of paper the right answer, and at the end of all the 50 slides, you can fill up the Google form, which is already sent to you, and you can send it to the concerned email.
Next week.
9:45. ఇప్పుడు ఎవరైతే
మూర్తిగారు వస్తున్నారు అదే నేనంటే
ఓకే తీసేద్దాం అయితే
తీసేయండి అది షేర్ తీసేద్దాం సార్
ఆ షేర్ తీసేసి నీ బాగా తెలుసా
అది ఆయన వచ్చేస్తున్నారు అందుకని నేను చూస్తున్నాను
నెక్స్ట్ టెస్ట్ కాబట్టి రెడీ అవ్వాలి. start. Okay. Photo రాట్లేదంటే వస్తుందా? ఇదేంటి నెంబర్లు ఏంటి ఇలా వస్తున్నాయి? రిటర్న్ గా రాలేదు కదా.
మీకు క్లాస్ కి తీసుకుందాం. మీరు కనబడాలి కదా సార్?
మామూలుగా కనబడతాం అక్కడ ఏదో ఫోటో ఉంటుంది. అది నేను నీకు పంపిస్తాను, అది మంచి పంపిస్తే వాడి తర్వాత. ఓకే, ఇది వచ్చినట్లయితే పంపిస్తాను. ఓకే. గుడ్ మార్నింగ్ చిల్డ్రన్. Sorry, we are delayed today by nearly about 15 minutes. It's a problem with the computer and also the net. So today actually we are going to start ocular manifestations of systemic diseases. If you are not able to hear me, please just make an alert, okay, so that we'll try to correct it. I think the ocular manifestations of systemic disease, I may take actually about 2 classes, maybe 2 classes. If I cannot complete actually today, it will be on Monday also. So later on, actually, you are supposed to give some seminars. So the topics and also the individuals who are interested with the job of actually giving the seminars will be sent to you by your WhatsApp. Okay, so get prepared, and we will definitely give you. We'll definitely give you 24 hours or 48 hours in a time in advance, and then you will have to present it on the day actually allotted for you people. Okay, so the ocular manifestations of systemic disease, it is actually is for completion's sake, and one should know actually what sort of symptoms or what sort of manifestations we have in the ophthalmological examination. We can find out, which refers to actually the occurrence of systemic disease at the same time. Okay, so most of the time actually what happens is we examine when we're on a routine examination of the eye, be it actually anti-segment or the posterior segment, we come across certain findings which are suggestive of actually the systemic diseases. In such cases, what we do is we refer the case to the physician or the surgeon or the gynecologist, depending upon actually the branch actually. We ask them actually to examine for the particular disease, if at all it is there or not. Naturally, the treatment of the particular disease will definitely try to rather lessen or slow down the manifestations of the ocular ocular manifestations. So sometimes it so happens that the physician, while examining the patient, they think that actually ocular examination should also be done because certain ocular manifestations will be present because of the systemic diseases, and also as a manifestation of the side effects of or complications of certain drugs. So they refer the case to us for examination. Okay, this is how actually it happens. So the first and foremost is the nutritional deficiencies which can cause an ocular manifestations. Vitamin A, you know pretty well that is xerophthalmia. It has been completely and fully covered while talking about the cornea. And vitamin B1 or thiamine, actually it causes the deficiency of it causes corneal anesthesia, conjunctival and corneal dystrophies, and retrobulbar neuritis. And vitamin B2 riboflavin, it causes photophobia, burning sensation, and vascularization of the cornea can also occur because of the deficiency of riboflavin. And vitamin C, the deficiency, it causes hemorrhages in the lids, orbit, anterior chamber, and delayed wound healing in case if there is an injury or in the post-operative period. Vitamin D, it causes a zonular cataract
and also the papal edema. So there are certain viral infections which can cause a lot of ocular manifestations. And the first and foremost is measles, which occurs in children. So here we see actually a catarrhal conjunctivitis and also complex spots. And the patients may land in actually with keratitis, dacryoadenitis, and uveitis. All these telltale signs of the uveitis and all these things will be present. And complex spots actually they are seen characteristically in measles. Okay. And next, mumps actually. In these cases, the patients may present with actually conjunctivitis, keratitis, and acute dacryoadenitis, and also uveitis. These are the manifestations of mumps which can occur whenever the patient presents with bilateral parotid swelling and all these things. Rubella is another condition where actually the patient may develop congenital malformations such as microphthalmas, congenital cataract, congenital glaucoma, and a chorioretinitis and optic atrophy. Whooping cough, this results in actually the subconjunctival hemorrhages and vitreous hemorrhage, and all these things can occur. Okay, so there are certain bacterial infections which may present with actually the ocular manifestations. In case of septicemia, it's blood spread of the infection. So there can be actually a metastatic retinitis, uveitis, and sometimes the patient may land in with the endophthalmitis. So diphtheria is another bacterial condition where actually we can see membranous conjunctivitis and sometimes corneal ulceration and paralysis of accommodation and also extraocular muscle occurs. And brucellosis, this is another condition where the patient may have iritis, choroiditis, and optic neuritis. So gonococcal infections, the patient may present with actually ophthalmia neonatorum or a corneal ulceration. So typhoid fever, so the enteric fever is actually usually the manifestations, ocular manifestations, they do occur in the second week of the enteric fever, and usually they may present with optic neuritis and corneal ulcerations. A meningococcal infection, they can present with actually metastatic conjunctivitis, a corneal ulceration, and paresis or paralysis of extraocular muscles, and metastatic endophthalmitis is another, and panophthalmitis can also occur in these cases. And tuberculosis is a rather a systemic infection which may present with actually an interstitial keratitis or a granulomatous uveitis. Eels disease is another thing, actually perivascularitis, which occurs in the children, in the males. So this is also thought to be actually tuberculosis etiology, and patients may present with actually papal edema, and also untreated actually it may go on to optic atrophy. So acquired syphilis is another condition actually where there can be an ocular manifestations. In the primary stage, actually, the patient may present with conjunctivitis and chancre of the conjunctiva. In the secondary stage, there can be a granulomatous iridocyclitis. And in tertiary stage, there can be actually a chorioretinitis, gammata in the orbit, and neurosyphilis associated with the optic atrophy, and pupillary abnormalities typical of secondary syphilis can occur. Argyll-Robertson people are these things. Okay. Congenital syphilis, the patient may present with actually an interior interstitial keratitis, an iridocyclitis, and chorioretinitis. All these things can occur. So leprosy is another condition nowadays. Actually, it is becoming less and less because of the intensive treatment that was given previously. But the people, they may present with actually cutaneous nodules on eyelids, and medarosis, that is loss of cilia, it can occur. And interstitial keratitis can occur because of the paralysis of the ocular muscles. So the closure of the eye actually may not be complete, and the patients may present with actually exposure keratitis. A granulomatous uveitis is another thing which can occur. A dacryocystitis is another complication which can occur because of the leprosy. So there are certain parasitic infections which can give rise to an ocular manifestation. So in case of toxoplasmosis, necrotizing chorioretinitis is one thing actually which is frequently observed. And in tinea, echinococcus, hydatitis of the orbit, vitreous and retina can occur. And tinea solium, cysticercosis in conjunctiva, vitreous, retina, orbit, and also in extraocular muscles it is seen. Toxocara endophthalmitis, actually it is a known condition. It is a differential diagnostic feature to be thought of in case of leukocoria. Onchocerciasis, we have been discussing it actually in community ophthalmology. The patient may present with actually sclerosing keratitis, uveitis, or optic neuritis and optic atrophy. So fungal infections, so in the body, it can give rise to mycotic corneal ulcerations, fungal endophthalmitis, and fungal infections of the orbit can also occur. So ocular manifestations of the disorders of the skin and mucous membrane. So in these conditions, in case of atopic dermatitis, a conjunctivitis, keratoconus, so that is nothing but actually an ectatic condition of the cornea, and cataract associated with atopic dermatitis is also known. And rosacea is another condition where actually the patients may have a blepharitis, a conjunctivitis, keratitis, and rosacea pannus in the superior limbus. Stevens-Johnson syndrome, it's one of the complications of sulfa drugs or other drugs, which can give rise to a lot of manifestations in the conjunctiva, cornea, giving rise to actually the conjunctival congestion, adhesions, and all these things. So endocrinal disorders, there are certain endocrinal disorders which can give rise to actually the ocular manifestations. First and foremost is galactosemia, congenital cataract can occur, homocystinuria, here actually you see subluxation of the lens, and mucopolysaccharidosis, so where actually you see corneal opacification, pigmentary retinopathy, and glaucoma, and also optic atrophy. And hypoparathyroidism is another condition where actually you see the fasciculations of the extraocular muscles. Cataract can also be seen. Optic disc edema is seen. And Wilson's hepatolenticular degeneration or Wilson's disease, we see here actually KF rings and also sunflower cataract. So ocular abnormalities in trisomes actually in certain syndromes actually we see. Trisomy 13 are Pato syndrome. So you see here colobomas, coloboma the lid, coloboma the iris, and coloboma the choroid, all these things can be seen. Coloboma of the optic disc sometimes can also be seen. And retinal dysplasia is another manifestation which we see actually in Pato syndrome. Cataracts can be seen, corneal opacities, and optic nerve hypoplasia, and cyclopia, and intraocular cartilage. These are the various manifestations which we may come across or examine them in case of Pato syndrome. Okay. Trisomy 18 or Edwards syndrome is another condition where we see a blepharophimosis, ectosis, epicanthal fold, hyperteliorism, microphthalmos, uveal coloboma, and congenital glaucoma and corneal opacities. These are the various manifestations of the trisomy 18 or Edwards syndrome. So trisomy 21 or Down syndrome, what we see here is mongoloid slant, almond-shaped palpebral fissure, epicanthus, telecanthus, narrowed interpupillary distance, esotropia, high refractive errors, and cataract, keratoconus, and iris hypoplasia. So these are the various things actually we come across and we see whenever you see a case of Down syndrome. Cri-du Chat syndrome, SHA, that's what we call actually, they say Cri, that means the cry of a SHA, that's a French word, that indicates it's a cry of actually Billy. Okay, syndrome. That's how what we see here is actually hyperteliorism, epicanthus, antimongoloid slant, strabismus, and Cri-du Chat syndrome 11P That's 5P previously. And what we see here is aniridia, glaucoma, and foveal hypoplasia, nystagmus, and ptosis. And Cri-du Chat syndrome, 13Q, we see retinoblastomas, hypertelorism, microphthalmus, epicanthus, ptosis, and coloboma cataract. So Turner syndrome is another thing where we see actually an antimanguloid slant, epicanthus, ptosis, strabismus, blue sclera, and a correctopia, an eccentric pupil, and cataract, and color blindness is mostly, it is actually red and green blindness, and pigmentary disturbance of the fundus. So these are the things which we see actually in Turner syndrome. Adverse ocular effects of common systemic drugs. So these are also very, very important, because in the most of the cases in the general medicine or anywhere else, when we use actually systemic drugs, you must know actually the doses, the side effects, and also the complications of the particular drug, so that you can stop it in the requisite time. Otherwise, it may go on to an irreparable damage. So CVS drugs, cardiovascular system drugs, so distalis can cause actually scotoma, disturbance of color vision. And quinidine, it can cause actually in optic neuritis. Thiazides can cause xanthopsia or myopia, or carbonic anhydrase inhibitors, it can cause hypertony leading to hypertonous maculopathy and the loss of vision and all this. Amiodarone is another condition which can cause actually corneal deposits. Oxprenolol is another CVS drug where actually it can cause photophobia and ocular irritation. So gastrointestinal system drugs, anticholinergic drugs, actually it can cause an acute congestive glaucoma and occasionally a cycloplegia effect. CNS drugs, barbiturates, which we used to use actually in convulsions or epilepsy. So extraocular muscle paralysis with a diplopia can be seen, a ptosis can occur, and a cortical blindness is also reported. And chloral hydrate is another drug actually which we use in case of epilepsy. And diplopia, ptosis, and meiosis, these are the things actually which are seen in case of chloral hydrate complications or side effects. Phenothiazines is another thing where the pigment deposition and oculogyric crisis can also occur. Amphetamines, there's another group of drugs which can cause widening of the palpebral fissure, dilatation of the pupil, paralysis of extraocular muscles, and loss of accommodation. All these things can occur. Paralysis of ciliary muscles can also occur. So monoamine oxidase inhibitors is another drug which can cause actual nystagmus, extraocular muscle palsy, and optic atrophy. And tricyclic agents, they can cause pupillary dilatation and also cycloplegia. So phenytoin, it causes nystagmus, diplopia, and ptosis. Neostigmine, it causes nystagmus and meiosis. And morphine, actually it causes meiosis. Haloperidol is another drug which can cause a capsular cataract. Lithium is another drug which can cause exophthalmos, oculogyric crisis. Diazepam, actually it causes nystagmus. These are the various ocular manifestations of CNS drugs. Okay, so the female sex hormones, they also are culprits of certain ocular diseases which occur because of it. And retinal artery and venous thrombosis can occur because of the female sex hormone. A papilledema can occur. An ocular paralysis, ocular muscle paralysis can occur. And with diplopia, naturally, whenever there is actually paralysis of the extraocular muscles, there can be possibility of a diplopia occurring. Nystagmus is another thing actually which can occur. Optic neuritis with optic atrophy, retinal vasculitis, scotoma, migraine, cycloplegia, and macular edema. All these things, they can occur because of the female sex hormones. So corticosteroids, they may cause actually posterior subcapsular opacity, posterior subcapsular cataract, and glaucoma. Steroid-induced glaucoma is very well known. And suppose if the patient is taking steroids, actually the occurrence of infection because of the immunosuppression can also occur. So there are certain antibiotics which may give rise to certain manifestations, ocular manifestations. The first and foremost is chloramphenicol, which we used to use previously for enteric fever, management of enteric fever. Nowadays, I think, I don't know whether we are giving it or not. So this chloramphenicol can cause an optic neuritis and optic atrophy. And streptomycin is another drug which we use, the first line drug which we used to give for the management of pulmonary and extrapulmonary tuberculosis previously, and it used to cause optic neuritis. And tetracyclines, they are the drugs which were commonly used previously for any infection. The first line of drugs which we used to use some 3 decades back. And this used to cause actually pseudotumor cerebri, and headache, vomitings, all these things used to occur. And when we stop actually tetracyclines, all the symptoms they used to recede, and patient used to have the benefit. So there are certain anti-malarials which can cause actual ocular manifestations. The first and foremost is chloroquine. Chloroquine, which is used in treatment of malaria, and also in case of rheumatoid arthritis and all these things. When we use it, after long usage of this thing, the patient is almost always sent to for an ocular examination. Suppose if he complains of a blurred vision or diminution of vision. So the one possibility is actually a bullseye maculopathy can occur in these cases, and central scotoma will be present, and pigmentary degeneration of the retina and chloroquine keratopathy is another thing. Etosis can occur, and electroretinographic depressions can also occur because of the chloroquine toxicity. So sulfonamides is another drug which we previously used to use a lot of times actually previously in almost ocular infections. The best drug of choice actually previously is some 3 decades back. It's only sulfonamide drugs. And the one complication, noted complication, is Stevens-Johnson syndrome. And ethambutol, which is used as an anti-tuberculous drug, can give rise to an optic neuritis and optic atrophy. Isoniazid is another drug, anti-tuberculous drug, which was used previously and even now, and can give rise to an optic neuritis and optic atrophy. Chelating agents, such as penicillamine, it causes ocular pemphigoid, ocular neuritis, and ocular myasthenia. So vitamin A excess, so it can give rise to actually a papillary edema, retinal hemorrhages, loss of eyebrows and eyelashes, and nystagmus can occur, and diplopia can also occur. Vitamin D, it can cause actually a bad-shaped keratopathy. Anti-rheumatic agents such as salicylates, it can cause nystagmus and retinal hemorrhages. Indomethacin, it can cause actually corneal deposits. A phenylbutazone, it can cause actually retinal hemorrhages. So categories of various systemic disorders which can give rise to the ocular manifestations. They can be either congenital, vascular, endocrine, metabolic, autoimmune, idiopathic, infectious, drug and toxins, already we have talked about it, and neoplastic and trauma. So whenever actually a patient comes to you or is referred for the verification of any ocular manifestations of the particular systemic disease, so the various examinations we do is, first of all, we take the vision. So the vision, a naked vision, and vision with pinhole, and suppose if the patient is already having glasses, with the glasses, and by doing a subjective verification, we see the best corrected vision. What is the best corrected vision also in the particular individual? And externally, we look at eyelids and make sure everything is normal. And then we examine actually pupil, and we look for direct and indirect pupillary reactions. And we also look for whether there is any relative afferent pupillary defect. And we also see if the pupils are normally reacting or not. Okay, and motility. So you look for actually the ocular muscle motility. Look in almost all the 6 directions. Look up, down, right, left, and also inferior temporal, superior temporal, and intranasal, superior nasal. All these movements also we see. And then we'll have to examine actually the anterior segment with this slit lamp microscope. And after that, we dilate the pupil and examine the retina, optic nerve, and also the blood vessels. And visual fields, either you do it with a confrontation technique, or if you have actually a Humphreys visual field analyzer, you can as well do a visual field examination by automatic Humphrey field analyzer. Okay. So in normal confrontation technique, you place your finger in different places in the patient's visual field and ask him if he sees it. Test one eye. We'll test one eye at one time, at a time. Okay. So there are a lot of congenital disorders with ocular manifestations. First, Down syndrome, Marfan syndrome, myotonic dystrophy, tuberous sclerosis, congenital metabolic disorders, lysosomal storage, and carbohydrate metabolism, neurofibromatosis. All these things, I think we have covered most of them previously. And this is Marfan syndrome, actually, where you see there is subluxation of the lens. Okay, this is actually the subluxation of the lens. You see the border of the lens here. So this is Marfan syndrome. The other manifestations are the patient is always lean, high arched palate will be there, syndactyly and will be present, and the length of outstretched hands is almost equivalent to the height of the individual, and the patient may have a ventricular septal defect, cardiovascular anomalies can also be present in case of Marfan syndrome. But the ocular manifestation we have is actually a subluxated lens. See, this is the border. So myotonic dystrophy, you see the corneal deposits. So this is neurofibromatosis, a coffee yellow spot on the abdomen. And here you see actually these nodules. The nodules are there. These are the nodules characteristic of actual neurofibromatosis. So vascular disorders with ocular manifestations. So either it can be because of the hypertension, or it can be because of migraine, or it can be because of various emboli from different parts of the cardiovascular system. And amaurosis fugax is another condition actually which we see. Okay, so the vascular hypertension, it affects eyes with the same way as it affects the rest of the body, the arteries in the rest of the body. Okay, so the main pathology is an arterial sclerosis and direct pressure damage. It's a number one predisposing factor for the eye disorders known as central retinal vein occlusion and branch retinal vein occlusion. So in a normal eye, the vessel walls are transparent and you see the blood, and red blood is seen through actually the vessel wall. And arteriosclerosis causes thickening of the vessel wall, and early sclerosis you see copper wire vessels appearance, and more sclerosis actually silver wire appearance will be seen. So arteries and veins, they share the same sheath. As arterial walls actually sclerose or thicken, the vein is compressed, and that's what is known as actually AV nicking, and it is seen in grade 1 hypertension. Actually, elevated blood pressure can lead to fibrin necrosis of the blood vessel walls. And we see exudates, cotton wool spots, and hemorrhages also in case of hypertension. Can also see macular edema, and in grade 4 hypertension, hypertensive retinopathy, we see actually papillary edema also. Nerve edema, disc edema will be seen. So this is a picture of actually hypertensive retinopathy. These are all cotton wool spots and hemorrhages, what we see here. Most of the places, this is also hemorrhage, and this is also hemorrhage. And this is again hypertensive retinopathy, the hard X-rays and also the cotton wool spots they are seen. This is again hypertensive retinopathy grade 4. You see actually the papillary edema here. So vascular classically it is taught in hypertension should be referred for ophthalmologists, usually whenever the patient comes with hypertension, or the gynecologist, when they come across actually a pregnant lady with pregnancy-induced hypertension and everything, so they refer actually the case for ocular examination. Suppose if it is the grade 4 hypertension with papillary edema and everything, so they may terminate the pregnancy also at the time. Preeclamptic toxemia individuals. So normally we cannot really do something as regards the ocular condition also. So the only thing is we will have to reduce the systemic hypertension. Suppose if the patient actually is having a systolic blood pressure more than 200, better refer the case to ER, emergency room, for emergency management and reduction of hypertension. So the vascular migraines, they are another class of conditions which can give rise to ocular manifestations. Migraines are actually, as you know, is a vasospastic phenomenon. Usually, their effects are temporary. The ocular manifestations are temporary, but actually they can be permanent also, like a stroke. So the various ocular manifestations which we see in vascular migraines are scintillations. And another thing is actually transient hemianopias or hemifield loss. And transient cortical visual loss can also be there. Amaurosis fugax, and rarely central retinal artery occlusion and branch retinal artery occlusion can also be present. So the management of the vascular migraines and various prevent frequent attacks, examination for any visual loss, consider discontinuation of oral contraceptives in case actually the patient is taking, as they can lead to a thrombotic events. Great. So we give actually flunarizine and also beta blockers for reducing it. So there are vascular emboli. So usually they are atherosclerotic and cholesterol plaques from the carotids that can be seen from other sources, heart and heart valves, and also IV drug abuses. Talc emboli can also be seen. They manifest as visual loss such as a central retinal artery occlusion and branch retinal artery occlusion. So here actually you see the various emboli. This is central retinal artery, and these are the emboli which we see here, and ophthalmic artery, and internal carotid artery. Okay, Syphilis. So these are actually cholesterol emboli which we see here, and a talc emboli in case of IV drug abuses. So vascular amaurosis fugax. It is amaurosis fugax is nothing but actually sudden painless monoocular loss of vision. Usually it manifests like a window coming down before, window shade coming down before the eyes, or dimming of the vision suddenly. And by definition, the vision actually tends to normal within a few minutes. It's usually caused by temporary arterial occlusion, central retinal artery occlusion. So vascular blood dysclariasis is another condition where actually you can see the ocular manifestations. One is hyperviscosity syndromes. So where you see actually thrombosis, including polycythemia, myeloma, leukemia, all these things. Thrombocytopenia, so bleeding can occur, and anemia and ischemia can occur, including sickle cell anemia, lymphoma. So this can also be manifest in the retina. So this is hyperviscosity syndrome. There is the tortuosity of the vessels is observed. So this is leukemia, where you see actually pre-retinal hemorrhages, lot of pre-retinal hemorrhages. This is again leukemia. Sickle cell anemia, retinopathy, And this is again sickle cell retinopathy. And endocrine and metabolic disorders. So primary disease in this category is, and the most common disease is actually diabetes mellitus. So the most common cause of blindness in the United States of America between the age of 18 to 74 is diabetic retinopathy. So 8,000 people become blind annually in US. Many effects on the eye are, there will be change of refraction. Suppose if the patient is hyperglycemic, so you may have actually myopic shift, hypoglycemia people, there can be hypermetropic shift. And diabetes, you know pretty well that actually it hastens the onset of cataract, and also it increases the speed of actually the maturation, and it causes cataracts. Typical cataracts can occur because of the diabetes, especially insulin-dependent diabetes mellitus. And most important is the retinopathy, the diabetic retinopathy, which is a blinding complication, and it should be prevented under any circumstances by proper management of the diabetes and early detection of diabetic retinopathy and its management. Okay. So this is diabetes mellitus. There is pathology of it, and NPDR, non-proliferative diabetic retinopathy. You see actually the exudates, and this is hemorrhage. This is macular nuisance. So this is again macular edema, clinically significant macular edema. These are hemorrhages. So in diabetes mellitus, NPDR, as it becomes more severe, there can be marked vascular tortuosity, and hemorrhages, more hemorrhages will be there, and cotton wool spots also will be seeing them. And proliferative diabetic retinopathy, it is because of the ischemia. So we get actually this proliferative diabetic retinopathy, new vessels will be forming, neovascularization will occur, usually on the nerve head or elsewhere, and vessels bleed into the vitreous, and fibrous tissue develop and cause tractional retinal detachments, and profound visual loss occurs in case of proliferative diabetic retinopathy. This is PDR, and this is actually NVE, neovascularization elsewhere, and this is NVD, neovascularization of the disc. And this is vitreous hemorrhage. This is a subconjunctival hemorrhage, and this is iris neovascularization, rubiosis iris. You see these red streaks over the iris. This is iris neovascularization, rubiosis iris. And this is a tractional retinal detachment. Okay. So PDR, it needs prompt treatment to prevent vitreous hemorrhages and also retinal detachments. Treatment causes regression of the vessels. That's what we do actually, PRP, pan-retinal photocoagulation. And treatment reduces visual loss by nearly about 50% of the cases. So PDR treatment, as I said, we normally give pan-retinal photocoagulation. Start at 1,000 to 3,000 laser burns throughout the retina. We should avoid macula, and it decreases actually retinal oxygen demand or need, which decreases the impetus for neovascularization. It is ischemia, which is actually an impetus for formation of the neovascularization. Suppose the retinal oxygen demand is reduced, so naturally the ischemia will also get reduced, and there won't be an impetus for neovascularization, and the patient improves. Okay, treatment needs to be ongoing. Actually, the treatment is lifelong, and these people will have to be followed up after pan-retinal photocoagulation every 3 months. And fresh blood vessels are there, we try to coagulate again. All these things will happen. So the treatment is lifelong almost. So laser effectiveness, PDR. So this is before and this is after. So the only thing that has been shown to delay the onset of and or decrease the severity of diabetic eye disease is controlling the blood sugar up. So in about 76% of the 76, if there is a 76% reduction from the basal level. So the onset of actually diabetic retinopathy is seen to be less. All diabetics need an eye examination at least once a year. Suppose if there is already a pre-proliferative or non-proliferative diabetic retinopathy, so these people, they should be examined at 6 months interval. Suppose if there is actually a proliferative retinopathy, proliferative PDR, proliferative diabetic retinopathy, so they should be examined at least every 3 months. So connective tissue disease, so these autoimmune disorders, these also they manifest with the various ocular manifestations. I think it's already 9:40. I think we'll take it up in the next class on Monday, okay? If you have any doubts, you can as well ask me now. Any doubts, or shall we call it a day? Okay, we'll take up actually for autoimmune disorders and other things on Monday, okay?